it gives me great pleasure to welcome to the microphone James, Kathleen and Georgina, who are going to speak on behalf of PWSA, and they're going to welcome us all and kick off our formal proceedings.
Well, firstly, obviously, thank you so much to everybody here tonight and at this conference. We've been just delighted with the turnout for the conference, and it's you people here in the audience that make it so special. We've had a busy year with Prader-Willi Syndrome Australia. Many of you might have seen online we've got a new website, and the very exciting thing about that website is that all the different components, the 60 or 70 resources, are web pages, which means that you can share those resources in 135 languages with people you know. So rather than having PDFs on there, we put web pages. And so Australia, a multicultural country, it'll be hard for them to navigate to the site and to find the information. So we're relying on you people to guide them and to help them find what they need in the language that is their mother tongue there, that they're familiar with. Now, would you like to have a chat first before we introduce Georgina?
Look, you've all heard probably a lot and enough from me today. But thank you, James. Thank you all for coming tonight. We are really looking forward. We've had a fantastic research program, and thank you again to Dr. Diane Webster for having put that research program together, and for all of the speakers who came today. Thank you so much for your time. I learned a lot. There's been so many new insights, and we're really looking forward to bringing those back to our community. And we're already thinking about how do we use those insights to shape our future research agenda, and how does Prader-Willi become the use case for the most leading edge thinking that was presented in the room tonight. But there is one particular comment that resonated with me, and I think will sit with me perhaps for the rest of my life, and that came from Deepan. And he said, the character of a society can be judged by how it takes care of its most vulnerable. That is what we're here for. So thank you everyone for coming today. We have learned about that in a lot of detail, about how to take care of our most vulnerable even better. And let's have a really great night tonight. Thank you.
So something that Kathleen and I are really focusing on, and our two committees, is hearing the voice of people living with Prader-Willi syndrome. And most of you were in the research conference today, which I've heard very many reports about, but some of us were in the Person with PWS conference, where we had 8 of our young leaders do their own presentations. And they did a marvellous job. We've managed to record them all, so we'll be able to share those little talks later on, but it's part of us training them to speak up and speak out for themselves in an environment of all teach, all learn, where they're experts as well as us. And so that day went very well too, and thanks to those guys here in this room tonight that gave presentations, and to their families who supported them through the process. Just before I hand over to Georgina, we have the Orange Hive at the back of the room. The Orange Hive is one of tonight's sponsors. We're very grateful that they've set up a chill room downstairs where there's movies and other things happening. So those that wish to move away from the dinner between entrees and mains are free to go down and watch some movies. Well, we're sure them will let them know when mains are served so that they can come back up. So if they want to gather at the back of the room, and thanks to the Orange Hive for setting that up. Now I'm going to hand over to Georgina to say a few words.
When you mentioned Prader-Willi syndrome in New South Wales, for many of us who've been working with people with PWS, the name Ellie Smith is very, very well known. And tonight, it gives me great pleasure to recognise Dr. Arabella Smith. Yes, Ellie's real name is Arabella. And we're privileged to have her with us tonight, brought here by her lovely daughter Natalie. Ellie was one of the first people in Australia to become professionally involved in the world of PWS when she was invited to speak at parent meetings in Campbelltown in 1979. And the diagnosis of PWS had started in 1978 in Australia. During the years of 1980 to 2006, Ellie published over 100 papers on research into the genetics, clinical features, birth and lifespan of all disorders on the 15th chromosome, and the majority of these papers pertain to PWS. She was the recipient of 16 grants for her research, which is pretty good. From 1994, she was recognised member of the International PWS organisation. She was the editor of IPSO International and then Professional, IPSO newsletter, and then she was the professional consultant to the board, including the chair of the Professional Advisory Board and the Australian Professional Delegate to IPSO up to 2005. Not only did she present at numerous state, national and international meetings and conferences and gatherings on PWS, she supervised PhD students, she taught other professionals about PWS, but she was a mainstream support person for families of children with PWS. And most families in New South Wales who were fortunate enough to see Ellie, and at that time I think they were the only ones doing the testing, she became one of their main support people. She was not just the geneticist. Ellie has attended all but one of the international Prader-Willi syndrome organisations, and that was the one in Cuba that we couldn't get her to go to. Notably, it was Ellie who nurtured the New South Wales PWS Association, and she pushed diligently for the establishment of an Australian PWS Association.
Founding member.
Founding member, absolutely. Ellie was also solely responsible for initiating the setting up of the Sydney Adult Prader-Willi Syndrome Clinic. Talks started in 1990 and we opened in February 1991. The clinic now sees adolescents and adults with PWS throughout New South Wales and consults throughout Australia. Ellie says, early diagnosis makes a big difference. Support organisations are strong, vibrant and make a huge difference nowadays. There is now a new way of caring for people with PWS, new activities, more understanding and a greater public awareness. An event like this shows it's in the proof. Ellie, I just want to say, members of the Australian and the international PWS communities can't thank you enough for your decades of expertise and support to people living with PWS, their families and other professionals working with them. You are invaluable to the PWS community, both in Australia and internationally. And to me personally, you have been an amazing teacher and a wonderful support. And from all of us, we thank you by presenting you with this award.
I've lost my voice, apart from every lot of other things I've lost. So, and I'm pretty old, and I'm amazed that you would give me such a beautiful send-off. But I've asked my daughter to do the thank yous.
Yes, thank you. So my name's Natalie, I'm Ellie's daughter, and she really just wants to say, well, no, I'll probably say more than what you would say, which is this has been a big part of your life for a long time, and indeed your entire family's life for a long time. I've known about Prader-Willi syndrome since I was this old myself, And yeah, she really, it's been a big part of her life, and she wants to say thank you to everybody. And it's been amazing to see the organisation grow in this time and to be what it is now. And she's loved every minute of her involvement with this group. So thank you very much.
Okay, that was beautiful. Thank you so much. Tony and Deepan, would you mind joining me on stage for our loosely termed fireside chat? All right, everyone, we're moving through our schedule, and this is the time in the evening where we get to have a fireside chat. Without any fire, but I think we can get through. It gives me great pleasure to be up here with Deepan Singh and with Tony Holland. I've had the opportunity to talk with both of you over the last couple of days. I'm going to dispense with formalities. Suffice to say, I'm not sure anywhere on earth you'd be able to get such a deep knowledge and understanding of the history and the position we're up to right at the minute when it comes to different ways of approaching Prader-Willi in the world today than you would by having these two gentlemen together. It's a very special thing, and I thank you both for being here.
Thank you for having me.
I'm going to jump over the formality, and I'm going to start with a question that's of some interest to me, and particularly given what we just enjoyed with Ellie a moment ago. I didn't realise how deficient my knowledge of the history of Prader-Willi was, really, until some of the things I've learned in the last couple of days. Tony, you mentioned last night that just by fortune you happened to be in a bar downstairs at a conference with a very important person in the journey of Prader-Willi in the world today. I was just wondering if you might be able to share with us a little bit of an understanding of the history of Prader-Willi as a syndrome, how it was identified, and how that knowledge has evolved since that time.
Right. I mean, Ellie, for example, will also know very much about this, but I think, as with so much in medicine, it starts with someone making some particular observation. You know, it may be about a particular illness or something, but in this case, it was about a group of children that Prader had seen, who he recognised seemed to have certain characteristics in common. And he described it as a syndrome of obesity, of hypergonadism, and I think there was a third factor that he particularly recognised in it. And as I mentioned, he then wrote that up in the German literature originally, and therefore it really wasn't known in the English-speaking world for a long time, which is sad, really. You know, and it was only much later that Bernard Lawrence in the UK described Prader-Willi syndrome in the same way, and I think in Bernard's case it was more adults that he met. He was an endocrinologist, and he did the same thing. He described a group of people that had certain things in common: the overeating, the hypergonadism, the short stature, and so on. And then what happens is, once you recognise that here's a group that may have the same condition, then of course people start investigating it, and you find, you know, ultimately you're looking for the cause of it, but you're also looking for the common diagnostic features. And this led to Vanya Holm really working together with other people to describe the phenotype of Prader-Willi syndrome, the early and late phenotype. And those diagnostic criteria and supportive criteria are really still used to this day. So you really move from the more anecdotal, if you like, to the more systematic evaluation. And then ultimately you look to the cause. And it really wasn't, it was in, I think it was 1981 or 82 that the deletion was first described. And it wasn't until the 1990s that the disomy was described. And then, in a way, things began to fall into place, and people realised that it was genomic imprinting that was really important here. You know, and then it went on, and I can remember geneticists early on saying, we'll have this sorted by the next conference. And of course they still haven't got it sorted. They had a lot of money, but they never got it sorted. And I think it just illustrates what we now recognize to be the complexity of the syndrome. The genetics is not simple, the other aspects of the syndrome is not simple, and certainly for parents, it's not simple to support their child with Prader-Willi syndrome.
I'm glad you said that. Oh, hang on. I'm glad you said that last point, and we'll come back to that second point you made about the complexity of the syndrome. But Deepan, I'm interested in the journey that you've been on, and I haven't given you time to think about your answer to this question, I apologise. I was just interested for my own purposes in what are some of the moments of clarity or revelation or understanding that you've seen among parents of people living with Prader-Willi more than once? You know, patterns emerging where you start to maybe look for, you know, on the journey that this family's on, these parents are approaching a particular realisation about life with Prader-Willi. What are some of those revelations or moments of clarity that you've seen?
There are many, and I bet if I share a few of these, there will be some oohs and ahs from the audience, because they might not have thought about that. For example, I learned from an imaging study done by Dr. Holland's team that there is hypofunctioning or reduced development not just of the hypothalamus, but many other parts of the brain, especially towards the base of the brain. And in particular, what interests me is a part called insula. It's called the hidden cortex. And why am I telling you this? Because this part of the brain is involved with detecting disgust or giving us a sense of disgust, right? So when my patients' parents say, I can't understand it, my kid, they're going into the garbage, they're going to the neighbor's store, my child is having, uncooked chicken and going into frozen food, that's disgusting, right? Everyone thinks that's disgusting, except many of our patients with PWS. And this is a revelation to the parents, because then they are not blaming the kids, they're not blaming themselves, they kind of realize that it's something that is very brain-based. To give you an example of something else, which is a revelation not just to the patients and the families, but also to the caregivers, right? We are psychiatrists, and unfortunately we have the burden of being, Freudian in some ways, and yes, there are lots of things that we've got out of that part of our, evolution as psychiatrists. But one of the painful, issues is that many of our colleagues think of people having some drive type of issues. So I've heard more than once about, again, people are having food, but it's important, rectal picking, for example, right? And it would be brought up, and I would get a call from a social worker, a psychologist, psychiatrist, and say, I think they're stuck in the anal phase, or this is something sexual. And just hearing from someone like me that, hey, listen, it's not sexual, because, about 30% of my patients have that, and about 60% have skin picking, and it's very brain-based. And guess what? There's a gene called nectin, which when knocked down, even in mice, they engage in excessive self-soothing behavior, excessive grooming behavior, so they're very rough with grooming themselves. That's because they can't soothe themselves with mild grooming. So that's a revelation to the parents, because then they realize it's not just a nervous habit, this is something very biologically based. And then they can kind of, relax a little bit about, blaming themselves on others and try to deal with the problem itself. And the clinicians can stop thinking of it as being something sexual and accept that this is a behavior which is neurologically mediated and needs to be treated as such. So just a couple of examples.
Yeah, I mean, I think in every part of life there's so much time wasted by worrying about something being almost a moral issue, or
Yeah.
you know, we're having the wrong set of expectations, and the amount of time you waste just feeling terrible about something that's not actually valuable to feel terrible. Yeah, no, that's
Absolutely.
that's really interesting. I'm going to just ask 2 more questions, and then we're going to. My beautiful assistant Kathleen will be roaming the audience with a microphone to take more questions. So start thinking about your questions. I must admit, you know, if we think about the genes, the body, and the mind, I must admit that I've probably spent the least amount of my time involved in this work thinking about the mind. That's the bit, and everything else I'm racing just to try to keep up with a basic understanding. And I just haven't spent a lot of time trying. In the preparation for this event, and then in the time I've been able to spend with you, I recognise that that's an imbalance. And I just wonder, in simple terms, how do you both think about the role of a prader who is living with Prader-Willi themselves in the care and in the treatment or the management of the symptoms and conditions and all of the difficulties that come with living with Prader-Willi? How should we think about, at a general level, the role of people who are living with Prader-Willi in doing good work to make this life better?
I mean, I tell you, the person that I've learnt most from about that issue is James, actually. And James and I, we would often have quite lengthy discussions about, in a sense, our failure, particularly in IPSO, to engage more with people with Prader-Willi syndrome. And I think to some extent we're going through, you know, these things go through phases. And I think we are now absolutely in that phase, recognizing that the new generation of children with Prader-Willi syndrome who understand they have Prader-Willi syndrome, who are beginning to understand more about the things that they have to struggle with in their life, like the overeating, are not their fault. But there are things that others can do to help them, and that you can learn to do them to help themselves, is really a new perspective. And I think that's very encouraging. And I think the tension the whole time, of course, for us, is to recognize how do you engage with people living with Prader-Willi syndrome in a meaningful and caring way, but at the same time, you acknowledge the risks that can come with independence or with relying, you know, on someone with Prader-Willi syndrome saying, I'm perfectly able to go down to the town by myself. You know, there are tensions there, but I think we are learning about how to do that, how to engage right from early in life with people with Prader-Willi syndrome. I don't know if that's your experience, Deepan.
Yeah, I think I'm going to say something a little controversial. Or maybe I shouldn't say it.
No, do it.
All right, so listen, it's about motivation, right? So like, we are social animals, we are driven by social status, right? We want to like rise in society, right? These are not relevant to most of our patient PWS. This will be like, you know, I don't have time for that, right? So they're not, so for us, we might want them to take the stage, but unless they want to do that, I think we're wasting our and their times. So I think we should do, you know, it's putting a burden on them which is not necessary, right? So yes, so lived experience in mental health, you know, there's a lot of peer programming and peer-based services for many illnesses like bipolar illness and depression, and perhaps there'll be a subset of patients who will be motivated to serve in that capacity, and they should be enveloped. But I think forcing that role is not, I don't think that's necessary or appropriate, and might cause too much of a burden.
I have many more questions and we could go very far down that rabbit hole, but I'm going to be disciplined. I have one more question before we open up to the floor. One thing I've noticed that's a bit of a habit of the human animal is to try to build and to store knowledge by categorization. It's a natural instinct to give things a name and to distinguish them from other things and to look at them in isolation. And so when we think about the different symptoms of Prader-Willi, I have sensed a way of thinking around if we can find a way to treat that symptom and then this other symptom, for example, mental health challenges and hyperphagia. And so naturally the human world starts to invest in specialisation and deliberate targeted attempts to address one or the other. I don't know that that is necessarily a reflection of reality in many different fields, and I just wondered if you guys could talk about, do you think the pathway to improving the lives for people with Prader-Willi is going to be a laser focus on targeting individual symptoms one by one? And in the case of hyperphagia and mental health challenges, are they actually separate? Can they be treated separately? Or are we ultimately likely to find out that many of these experiences are actually deeply, deeply connected in ways that teach us something about every human?
I think we should ask Deepan to start. Fairly straightforward question you've just asked. Deepan, what do you think?
All right, so listen, it's like, so we have to first, agree that we are talking about individuals who happen to have Prader-Willi syndrome, but they have they're allowed to be sick with other things as well, right? So one of the biggest problems in our community, especially folks who are taking care of our patients, but they don't have enough experience with enough patients with PWS, is that everything then is PWS. They don't see autism, they don't see depression, they don't see bipolarity, they don't see psychosis, they don't see anything else. Oh, it's all PWS. So really having a more humanistic approach to the person and seeing that, just like, if I have, whatever, diabetes, hypertension, whatever, cancer, whatever, I'm a person with that, right? I'm not a diabetic, right? I'm not a, whatever, hypertensive. So similarly, there's a person with PWS, so they are allowed to have different things. And I think one of the biggest, things to understand is that because they can have more than one thing, and the syndrome is not like a single gene defect, there are lots of downstream effects. It would be important to use all the technology available to you to treat your child. So like, for example, if you are living in today's world, right, you want your Netflix, you want your Google, you want your Meta, you want your electric car, you want your petrol-driven car also, and you want the lights, and you want TikTok and everything else. You're not okay with just having a fridge in your room, are you? So why are you okay with accepting just one piece of technology and not everything that is available to your child? I don't get it. So bottom line is that if you're a doctor and you think that there are more problems to solve than can be solved with one medicine or one treatment, please consider all of it and take it as human-made technology which has been built to help you, rather than a medicine which comes with so much connotation, and stigma.
The individual logics of each piece of the diagnosis are just infinitely less important than the human being that you're actually dealing with.
Yes,
that's what brings everything together.
Right.
The human story.
I mean, I don't disagree with that, but in a way, of course, to make advances, you at times have to split something off. In medicine, there's this phrase of lumping and splitting. So and it's medicine was founded, and really modern medicine was founded around the process of diagnosis.
Yeah.
And of course that was really important when it came to infectious diseases, for example. When antibiotics came, you needed to be certain that someone had pneumonia and they had bacterial pneumonia rather than viral pneumonia, because you knew that would respond to antibiotics or whatever. Of course, that doesn't work so well for when you have a syndrome, and a syndrome by definition has many different symptoms to it. And I think part of the challenge of research is to ask the sort of question that you asked: to what extent are these symptoms related? To what extent are they what we would call comorbidities? So in other words, something else that has developed, which any of us could have had, but happens to have developed in someone who has Prader-Willi syndrome. And there are places for that lumping together or splitting apart. But as long as you're aware that you're doing it, and at the end of the day, you bring it all back together in the way that you describe. But you know, when you look at the people I work with who do brain scanning, they are excellent about how you do brain scanning and how you interpret it. But they may know nothing about comorbidities or about genetics or whatever. So you know, you allow them to be very focused, but you make certain that others are involved that try and then have the skills and ability to bring it together. That's for me really one of the most exciting things, is to try and stand above all of this and say, how does it fit together, or does it fit together, or is this by chance, or whatever. You know, and I think, Ellie, of the times we've talked about these things, that, you know, so often one realizes that the way we thought about it in the past is no longer correct, and one has moved to a different way of thinking about it. And that's, it may be 2 steps forward and 1 back, but that's how knowledge advances and new treatments are eventually developed.
I'm going to ask my assistant to look for a question. While she's doing that, I'm going to be just self-indulgent. You reminded me of something I wanted to ask you, Tony. Yesterday, or this morning I think it was, you talked about feelings as if they were an indicator of how the body regulates itself.
Right.
And I've been thinking about this for a long time, and I thought to myself, but what if the purpose of the body is to give you a set of good feelings? How do you grapple with those questions of exactly who is the human being that is the focus of the work? Where does the conscious person live? How does the body relate to the feelings, to the mind, to the genetics? Are these questions that shape what you do, or are they just the ramblings of an outsider?
I think for me, you've touched on a bit that one of the things within medicine, psychiatry tends to be the bottom of the medical heap. But actually, psychiatry touches on such fundamental issues as you've just raised. You know, it's about what is the mind, what do we mean about the mind, what do we mean when we talk about feelings, and what about when feelings, or the feelings that someone expresses, don't meet the reality as you see it. So, you know, maybe someone is saying that they want to harm themselves or kill themselves, and you know that a few weeks before they weren't like that. You know, that creates, you know, is this depression? What is going on? I mean, for me, and I did quite a lot of general medicine before going into psychiatry, for me that is the exciting aspect of psychiatry, is to try and explore these things. And however inadequate I and others might be about that, it's you know, that's what's challenging. Much more challenging than the heart or the kidneys or, you know, or whatever, or maybe, dare I say it, anesthetics. I mean, and his daughter's an anesthetist.
Well, I think we have a real question.
Can I just take a stab at that question?
I'm sorry, just very quickly.
Just one, yeah. So, and you know, I would encourage you to read Robert Sapolsky's books if you're interested in this, especially a book called Determined, which answers your question in neurobiological terms. But what I got, I mean, out of that, you know, and many other texts and patients and just human experience, is the concept of emergent complexity. So which means that, okay, if you just look at a brick, right, you're unimpressed. You're like, oh, it's just a brick, right? But if you look at the pyramids, right, it's you know, it's really impressive, right? You look at a cell, right, taken from an octopus, you're unimpressed. But you look at the octopus, that's impressive. So the mind, right, is so complex and beautiful, and so, you know, and we are in it, we're immersed in it, and so it's very hard for us to accept that it is an emergent complexity over millions of years, right, which is impressive, but it doesn't mean that the deterministic small pieces are still nuts and bolts and, you know, neurons and, you know, membranes. And that's why the work that our basic scientists are doing is so important, because they break it down to the very basics and luckily we work well with them, so they know that we need to keep that emergent complexity in mind. But the mind is the brain. There's no difference. Yeah.
We're not going to argue about that. We're going to
Would you agree with that?
I'll bite on the controversial statement on behalf of my daughter. So in terms of the burden, you know, I personally, and I think she would feel the same, is that I would never think that it's a burden to ask her opinion on something. And let me just frame that by saying, in January, I'd never ask my daughter, do you want to go away next Christmas on holidays? Because that would be a burden on everyone for the whole year. But I think it's important to have, as much as possible, our people who know best involved in their care and their treatment to the level that they can, under the guidance of their caregivers and their families. I think it's extremely important. And what I don't like to see, and you said that now we seem to be on this thing where we're asking people and person-centred approaches, etc., toning, that's tokenism, and that really annoys me because it needs to be genuine. If you're going to ask someone, you want to know what the answer is. If you don't want to know the answer, don't ask them. You know, so I think that it is important to ask our people that we know with Prader-Willi syndrome everything that we can, because I've learnt the most from her than I have from anybody else.
Right, and apologies if that is how it came across. I meant that the burden of being put on the stage, that's different from being heard. Like, obviously, we must talk to our patients and our loved ones. That's the first thing that we do, right? And we can put it in the context of their environment, and that context can be given by the caregivers. But the voice of the patient is most important, and that's one of the biggest weaknesses of the hyperphagia questionnaire that we use in research right now. And that's a real weakness, and that's one of the big reasons we are having trouble in getting approvals from the FDA, because it misses the patient's voice, right? So we are trying to include that. I meant it's kind of akin to the diversity burden, right? So if you have, like in the US, that's a big problem. If you have a black colleague, everyone is putting them in the position of, you know, going for talks for, you know, implicit bias training and racial trauma and stuff like that. Why? It shouldn't be their job alone, right? So that's what I meant. So to expect that our patients, unless they have the motivation, we don't need to give them a mic and say, now you must talk about PWS. Now with their doctors, with their parents, it's important that their voice is not only heard, it's understood and taken very seriously. So I'm sorry if I wasn't clear earlier. Yeah.
We have a question over here.
Oh, beautiful. Let's go.
Hi, my name's Sally. I've got a 6-year-old son. Apart from your own amazing work that you're doing, what research in the community are you most excited by?
You know, research in the communities, or within the Prader-Willi community. I suppose, I mean, for me, in some ways, I think I've got to my retirement too early. I think this is, you know, what I think excited about is the reality of some new treatments. And I don't think we could have anticipated that even 10 years ago. And we've seen a real resurgence of thinking, particularly around hyperphagia, but also around, you know, the emotional outbursts and so on. And when you think that growth hormone really came on the scene in the 1990s, I mean, Sweden and Europe led the way in the trials on growth hormone, and they were done in the States and so on. But that's been the only formal medical treatment, if you like, that's been available. And I think we could see some really new treatments. The other thing, just to emphasize, and I think we are, and us as medics are in real danger of this, I think, is that one thinks of treatment too easily as a tablet. I think understanding Prader-Willi syndrome and helping families understand Prader-Willi syndrome is treatment in its own, in the broad way of thinking about treatment. So I do think that the advances in the way one can reflect on and understand the needs of someone with Prader-Willi syndrome have advanced. I know it's frustrating that it hasn't led as yet to formal treatments, but I think what you as parents of younger children understand about Prader-Willi syndrome will be so much more advanced than, say, James, when your son was born, it would have been then, or people whose children were born now, who are now in their 40s and 50s. It would look so primitive what the families understood at that time in comparison, I think, to what people understand now and what families can expect to understand about the condition. So I think that and potential for new treatments for me are really exciting.
We have another question.
No.
We have another question.
Is it on?
Yes.
Hi, I'm a mum of 3 beautiful children. My youngest, who has Prader-Willi syndrome, is 13. In your opinion, why do you think, I know when Tobias was born 13 years ago, in Australia I found it really difficult to find any information and did look abroad to get what I needed. It seems very obvious that there's a higher prevalence now of Prader-Willi. Is it, in your opinion, why is that? Why is that happening? Why have we got such a wider community now? Why is there so many?
You go first.
Okay, again, it's not been studied. There are more people in general, point number one, across the world. Point number two, people are living much longer, right? And diagnostic tests, awareness has gone up. I think those play a big part. Similar to autism, there's some suggestion that advanced paternal age
For the diasomy form.
For diasomy form. But other than that, if the question sort of wants to ask if there's something changed in society or environment or the food we eat, or there's been no link to that. And the increase or the prevalence is so uniform across the world and across cultures that it's near impossible to call it due to any particular reason.
Just to follow that bit, within the International Prader-Willi Syndrome Organisation, we're now getting much more involved with African countries. And there, of course, if you go to those countries and you say to people that, have you heard of Prader-Willi syndrome, or do you know of anyone with Prader-Willi syndrome? I know in Kenya, for example, we've done quite a lot of work, and they say we know of 3 families or 4 families. I think there's a really difficult issue to be explored. One is, I think, clearly the pediatricians are not recognizing it. There may be issues of stigma, which mean that children are hidden. But I think the more distressing aspect may be that certainly in the more rural areas in some of these countries, the young babies, the young children may not survive childhood. I think if they do, in some of these countries, food isn't so readily available. So as they become independent, the risk of obesity, paradoxically, isn't so great. But I think there's a lot, I agree entirely that I think there are not going to be cultural influences on the incidence of these conditions.
I can't hear that. So what we're going to, no, it's not just that.
Sorry about that at the back. But I think it's likely the incidence, the birth incidence will be similar across countries, but the population prevalence will be different because of differences in mortality rate, for example, so in life expectancy. So the population prevalence will probably be increasing in countries where there's good health care, good social care, but still much lower in countries where there's a high early mortality rate, or something like that.
Are there any questions?
Hi, I just want to ask about how we can go about improving psychiatric expertise. Families nowadays, they usually get good support from their endocrinologist, but when it comes to later on and they need the psychiatric support, it's very hard to find a psychiatrist who doesn't just go down the normal route of treatment that they would for someone who doesn't have Prader-Willi. And it's just a struggle that a lot of families have. And I think that's the same in other countries as well. We're from New Zealand, but I was just wondering what we can do to try and share expertise. And we're really grateful that you share your expertise with the Prader-Willi community and as parents, but how can we share it further amongst the doctors that we need to understand?
So before you do, can I just check, can you hear down the back now?
Can you hear me back
Can you
there?
hear at the back?
Yeah.
Thanks.
Yeah. I think you raise a really important point, and I don't understand why psychiatrists aren't more interested. This may not sound a very nice way of saying this, but the one advantage of Prader-Willi syndrome is that it is very interesting. And when I saw the first person that I saw with Prader-Willi syndrome, I was fascinated by it. It raises, as we've discussed already, so many questions about the brain and the mind and so on. I don't know what it is about psychiatry. My own feeling in the UK, it's got a bit stuck in some ways. The advantage we have in the UK is there is a sub-discipline within psychiatry, of the psychiatry of intellectual disability, which is what I specialised in after doing general psychiatry. So we're psychiatrists that specialise in seeing people with intellectual disability who have mental health or behavioural difficulties. And of course, Prader-Willi syndrome falls within that category very, very well. And I think you have that here, but in a few centres. So Julian Troller here in Sydney would be someone who's a psychiatrist who has a special interest in the area of intellectual disability. I think we've got to get to our trainees at a much younger age and actually demonstrate to them that this is a really exciting and important area to work in. Not exclusively Prader-Willi syndrome, but this area of intellectual disability. And just very quickly to say that when I was training in psychiatry in London at the Institute of Psychiatry, I was in America for a 6 months exchange, and I'd met the person who became my wife whilst there, and I hadn't done very much psychiatry. And when I was asked where I wanted to rotate to next when I went back to England, I mentioned I wanted to do child psychiatry, and I in fact got sent to intellectual disability services. And I remember thinking at the time that this was a sort of punishment because they discovered I hadn't worked very hard in America. But that shows the attitude that I had and other people had. But then once I engaged in the field, I loved it. And you realize that actually you could make enormous difference to people's lives by understanding the issues that they faced and the behavior problems that they had. But I think there's still almost a fear of the field of intellectual disability, which has a rather tragic and problematic history, of course.
Can I just say something to help you out as a local? We have a major problem. I'm a bit of a provocateur. We have a major problem in the world in psychiatry, and if you can use your vote, they're training in the wrong areas. We've got the wrong people. I don't know. Then the young psychiatrists are not getting exposed to interesting branches of psychiatry like intellectual disability. We had to fight to get Marissa Portelli, who's fantastic, who's got an interest in intellectual disability, to work with us. Her boss is making it difficult for her to work with us. Her boss is making it difficult for her registrars who want to work with her to work with us. Instead, we're spending money on this thing called Headspace, which is for the worried well, and they don't actually look after people with severe mental illness. They do not look after you if you have schizophrenia. It is it's outrageous, and we should all be yelling about it and making a fuss with our local members, because we've got people killing people in malls in Bondi Junction because they can't get treatment for schizophrenia. They can't be housed. Homeless people with schizophrenia cannot be housed. So we've actually set up a charity to support these people. I'm not allowed to say that, but I'm very passionate about it, and I'm very angry about it, and it's really appalling because it is such an important. I said to the hospital, if we don't have an intellectual disability psychiatrist working with us, because I've had to make all the decisions. Luckily, I'm married to a very embarrassed psychiatrist who has advised me about what to do with my patients, so they've had some care, but I've been a bit nervous about it. But it's such a crucial part of the treatment of somebody with Prader-Willi syndrome. Last one. But I was just answering your question. I think it's really important. Sorry.
Hi, I agree with that. I think it's so important to get comfortable in this space because it is treatable. So that's the scariest part, is that we have something that is completely treatable, but everybody's just scared of it. And I just think it's unacceptable now.
I got the mic.
We do need to run a little bit to schedule. If there's one more burning question that needs to be asked, we'll take it. But going once, going twice. We've got a hand up. All right, this is our last question.
I almost think it's a right of rebuttal at this point. I just wanted to close it off by saying thank you to both Tony and Deepan for coming and sharing their knowledge. As they said, and as I've heard from so many families within the last 24 hours, is that psychiatry is something that is greatly lacking in every state in Australia and New Zealand, because we're the College of Australian and New Zealand. But thank you so much for your knowledge. Thank you for all your publications. Thank you for your book, because it means that psychiatrists who can't access this training formally can actually have some knowledge and have some reference point to understand how to treat people with rare diseases. So thank you.
I think that's it. Thank you guys so much.
Can I add one thing?
Yes, please, Kat.
This is a great conversation, and this is why we have Dr. Tony Holland and Dr. Deepan Singh here together from Europe and the US to bring the best of Prader-Willi psychiatry to Australia. And it's because of this very issue that we've been discussing right now, which is the lack of access and availability of good mental health support to our kids and our adults with Prader-Willi syndrome. So thank you all for this conversation, and again, thank you to both Tony and Deepan for coming all this way. Now, Georgina.
So I just want to mention, Tony, you didn't mention the mental health initiative from IPSO,
Right.
and I think that probably deserves a mention.
Yeah.
Please.
Yeah. I didn't mention it, Georgina, because I've been really rather slow at completing it, and so I was sort of hiding from that fact. But it's been a very exciting initiative. So I think in IPSO we would get many questions from different parts of the world, from families, largely from families, but also from professionals, to say, what do we do about the fact that my son or the patient that I'm seeing with Prader-Willi syndrome is very violent at times, or they've changed in some way, and how can we get help for that? But we realised that there was a real need to try and bring together the knowledge that does exist about how you understand the mental health needs of people with Prader-Willi syndrome into one place. At that time, Deepan, your book hadn't actually come out yet. So in a sense, that gap has been to some extent filled, I think. What I think the Mental Health Initiative does is bring the sort of perspectives from people from different parts of the world. And one of the things about this area of work is that there are different ways of thinking about it, both culturally, intellectually, from different disciplines. And so we attempt to bring that together, and we will be launching the report in Phoenix in 2024. I promise. Thank you.